Good morning, everyone. Welcome to the October 15th, 2024 meeting of the Behavioral Health Committee of the Incarceration Prevention and Reduction Task Force. I'm Stephen Gockley, co-chair, along with my fellow co-chair, Dan Hamill. We'll call this meeting to order and start with the land acknowledgement statement. Before we begin, we acknowledge that we are gathered on the traditional and unceded territory of the Lummi, Nooksack, Samish, and Semiahmoo people who have cared for and tended this land since time immemorial. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We pay respect to their elders, past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us together here today. And please join us in uncovering such truths at any and all public events. Welcome, everyone. I'm glad we've had some people joining. Before we head into agenda items, because we do have some new people here and some designees, we thought it would be a good idea to go around and introduce ourselves so that we all are familiar with what perspective we're coming from. And I will begin. I'm Stephen Gockley. I'm the co-chair, former co-chair of the task force itself, retired legal aid attorney, co-chair of the Health and Community Services Behavioral Health Advisory Committee as well. Dan?
Dan Hamill, Bellingham City Council President and co-chair along with Stephen Gockley. Good morning.
Brian?
I'm Brian Estes. I'm the treasurer of the National Alliance on Mental Illness, the Whatcom County chapter.
Dr. Wu?
I'm Xiaoying Wu. I'm a retired family physician and intern at the Chuckanut Health Foundation.
Thank you. Hannah?
Hi, I'm Hannah Fisk. I'm a special projects manager in the Response Systems Division. I'm the designated alternative for Melora.
Mike?
Yeah, good morning. Mike Hilley, Emergency Medical Services Manager for the county. Been on this committee for a little over 6 years and also chair a couple of EMS committees around the region. So good morning.
Morning. Jake?
Hi, good morning. Jake Webush, Administrator with District Court and with District Court Probation. Nice to see everyone.
Thank you, Jake. Steve?
Steve Larson, community paramedic with the Bellingham Fire Department.
And Deborah? You're muted, Deborah. Deborah, you're muted.
So you can tell that I've missed a couple meetings. My name is Deborah Hawley, and I am the mother of an incarcerated son, decades long. He spent a lot of time off and on in the Whatcom County Jail before he went off to prison. So I am on this committee and the general larger committee as representing the role of consumer, since I have a son who has been and is a consumer of the services. I do a lot of criminal legal system reform work. I have a support group that I started about 14 years ago for those in Whatcom County who have loved ones in the county jail or prison. Thank you.
Thank you, Deborah. Dr. Safford?
Yes, I'm Bertie Safford, a retired family physician in Ferndale. I'm on this because I'm a member of the larger task force, and I'm always very interested in this aspect.
Thank you. Pam, and welcome.
Thank you. I'm Pam Jacobs. I'm the Behavioral Health Director at Unity Care Northwest.
Okay, and we have our two indispensable support staff, Jill and Jenna, with us as well. So we'll start the agenda, and the first thing we have is a long deferred, and thank you, Brian, for your patience with that, presentation. I think that originates within NAMI, but is a relevant topic to everything we do, entitled How We Talk About Mental Health Matters. And Brian is going to present the slides, and hopefully we'll generate some discussion out of this for how it applies to our work. Brian.
Thank you, Stephen. Welcome, everyone. What I want to talk about this morning is how we talk about mental health matters. And we're going to talk about the concepts, the linguistic concepts of framing and messaging. But before we do that, I just wanted to set the table a little bit about how we use or how our language defines mental illness and behavior. So first of all, I'd like you to meet Linda. She's been diagnosed with lung cancer. I'd like you to meet Larry. He's been diagnosed with bipolar disorder. Linda and Larry have both been diagnosed with medical conditions. But do we think about them differently? And if so, why is that? I just want you to keep that kind of in your back of your mind as I go through the next set of slides. I was going to have discussion, but I think I'll defer that for a moment. So, and for some of you, this is obviously a refresher, or you're very aware of this. For others, it might be some things that they're hearing for the first time. So mental health disorders in general are greatly misunderstood and stigmatized as their behavioral or moral failings. But there's a number of much scientific research refutes this, as such disorders are really biological, genetic, or the result of environmental factors. So the DSM, or the Diagnostics and Statistical Manual for Mental Disorders, which I believe is published by the American Psychiatric Association, defines a mental health disorder as a syndrome characterized by clinically significant disturbances in an individual's cognition, emotional regulation, or behavior. But what causes those? So mental health disorders are biological. They result from changes in brain structure, function, or chemistry. They often are genetic. Many health disorders, including bipolar and schizophrenia, have a genetic component, and people have a family history of that. And many disorders require medical treatment as well as therapy, as well as use of psychiatric medications for treatments like antidepressant, mood stabilizers, and antipsychotic, because they correct imbalances in brain chemistry. So many mental health disorders cause dysfunction in the brain with changes in mood, behavior, and perception, and you simply can't will yourself out of these conditions. Someone with depression, for example, cannot just snap out of it because the disorder stems from biological changes in brain chemistry and function. So the term behavior or behavioral refers to what I would characterize as actions or patterns that are learned or influenced by external factors such as environment or upbringing, and they often are under the control of your conscious mind. So in contrast, mental health disorders, behavioral problems typically involve habits or responses that are developed through conditioning, experiences, or social influences. So one of my big takeaways from my presentation this morning is mental illness affects behavior, and behavior can affect mental illness, but mental illnesses are not behavioral. Now, the name of this committee, and behavioral is used, obviously in many, many, many settings. NAMI's, the National Alliance on Mental Illness, their official position is that they really don't favor using the term behavioral health because it implies it's a conscious decision or it's something it's a choice. And so they prefer the term mental illness or mental health disorder. So, are some people with mental health disorders, especially those with serious mental illness, are they aware of their condition? And the answer is no, or often no. And there's a term for this that is very difficult to pronounce. So I've included the phonetic, and it's called anosognosia. So Bertie and Dr. Wood, did I pronounce that correctly?
Close enough.
Yeah, okay. So it's a condition where a person is completely unaware of their own mental health condition or neurological deficit. This lack of awareness is not just denial, it's result or damage or dysfunction in certain areas of the brain, often affecting self-awareness. And this can occur in various mental health disorders, schizophrenia, bipolar, as well as brain injuries like strokes. And the longer someone is in this state, and Dr. Wu in our discussion might provide more context, or other professionals here on the call, can actually alter brain chemistry or brain function. So it's a very important concept, both medically, and when somebody's having a psychotic episode in downtown Bellingham, you often can't really talk to them perhaps in a real rational way because they're simply not aware that the way they're behaving. So why don't we just stop there? And I'm just wondering if there's any people that have any comments or questions on what I presented so far.
Good morning, Brian. Mike Hill here. Oh, I'm sorry, Dan. Go right ahead. I didn't raise my hand, so I'm sorry.
No, go ahead, Mike. It's fine.
But no, I was just going to say I deeply appreciate this because we have these discussions in EMS quite a bit. Because as our responders go on these calls out there, there's kind of a determination on how to handle these. And I've always advocated these were medical conditions. These were medical things that were affecting the patient. And we should talk about them in a clinical way, not so much a law enforcement way, if I'm saying that correctly. And then how we treat these patients on down the line in the hospital, because we see them acting out, and doing things in public, and it's just considered a bother, but we really don't understand what's underneath all that when people are acting out or in crisis, etc. So I really appreciate you bringing this to the table.
Others have comments? I'm not checking if anybody raised their hand. Just go ahead.
I'll do that, Brian. Dan, go ahead.
Yeah, that's fine. I feel like thank you. I feel like sometimes in the context of this meeting that I feel like I'm back in class at college, and we're actually kind of learning some things here. And for those that do this work every day, thank you for the work that you do. I think it's important for us to kind of be reminded of the broader context. And Brian, I really appreciate you bringing this up, and I agree with Mike Hilly that this is really a medical issue, and treatment it would be pursuant to that. And I think that we maybe words matter, and we call ourselves the Behavioral Health Committee, but I think that having that framework and context with mental health illness is very important. So I appreciate you bringing this up today. And sometimes in the context of this meeting, sometimes we learn and sometimes we do. Today we're learning, and next time we'll do. Thank you.
Yeah, Brian, I also want to thank you for bringing this up. Well, I look at it this way, we have diseases which are invisible and asymptomatic, like hypertension, right? And we don't blame people for those, although some of that is behavior related. But I think with mental illness, I've often told people that, the symptom of the disease is a thought or a feeling or a behavior, but it's still a disease, right? And so, but the fact that it's a thought or a feeling or a behavior comes across to other people as if it's a choice. But those thoughts, feelings, and behaviors are actually symptoms.
That's extremely well put. Thank you for that comment.
Birdie's got her hand up.
You're muted, Birdie.
Okay, I just wanted to weigh in as well. I think on both points, I really agree with the differentiation between behavioral health and mental health. And I think the kind of public pendulum is swinging toward behavioral health for whatever reason. And one of the roles we can play, both on this subcommittee and on the IPR task force, is helping to educate the public. And so I totally agree with whether we change the name of the subcommittee or not, being very mindful about the words we use, because mental health is definitely an illness. And the second point I want to make is what Brian also referred to, is people genuinely are not aware of their illness. And because of that, the behaviors that they often exhibit that are so troublesome are what any of us would exhibit given the way they're perceiving the situation. And I think that's a really important reminder for all of us who deal with these people. If they're acting frightened or combative, they're probably perceiving a genuine threat to themselves. And so that definitely determines how we deal with them, and the inability to rationalize, you're doing this and therefore we're doing that, is not a useful approach. So thank you for highlighting that, Brian.
Thank you, Bertie. That's really a very, very thoughtful, and I really appreciate you underscoring sort of the title of this presentation is how we talk about mental health really matters. So is there any other comments or questions? I'm going to move on and talk about the kind of framing and messaging component.
Mike, go ahead, and then I have a comment too, Brian.
Yeah, thanks. And just a short one, Brian, I would also submit that this really also applies to our opioid crisis that we're having now. I don't think anybody really meant to be addicted like this, especially with the grip that fentanyl has on people. And it does cause behavioral health issues, even when you wake somebody up, to have a clear conversation. There's still something going on under there. So I really think this is appropriate as part of that conversation as well.
Mike, I recently came across somebody who I thought wasn't breathing and slumped over in the sidewalk, and I called 911. And they said, can you go back to that person? And I said, yes. He says, so go back to them and tell them, yell in a loud voice, hey, I'm with 911. Do you need medical attention? And the guy, I kicked his foot a little bit, and he goes, oh, yeah, I'm okay. Thanks for asking. But but I've also heard when some people give somebody like Noxalone, they're very angry because you've taken the high away from them. But yeah, absolutely. Thanks for that comment.
Can I throw something in there really quickly too? The move to using behavioral health, I think, was to bring mental health kind of on a, we'll say, states, plural, bureaucratic issue, which was to bring addiction and mental health services under the same umbrella. So I think that's one of the reasons, because if you say, unfortunately, Brian, if you say mental health, people sometimes can get the idea that you're excluding addiction. So that's just a cross we have to bear, is how language has been used historically. So I just wanted to throw that in there.
I mean, it's codified all over the place, so it's a term that's out there. We're not, and even NAMI, Washington, there's no reason to not use it. But I think people at the same time need more education to understand that we're really talking about medical conditions. But thanks, Pam.
Yeah, and Brian, I was going to say exactly what Pam did. Thank you, Pam. The trend that Bertie noted, I think, was an attempt to be inclusive of broadening a scope of focus. And at the same time, your point makes me think a lot more and a lot differently about how we denominate these things. But it also makes me think that from a community perspective, which is what I think we're working on in a certain way, people are concerned about the behaviors someone who is asymptomatic or being effectively treated symptomatically, at least, it is not someone that, you know, people have a concern about in the community so much. They're willing to allow it to be a medical condition being treated. It's the behaviors that tend to be focused. And so I wrestle with what we call it and what the actual concern that we're facing in the work that we're doing here in this committee and many of you in your professional lives. And I don't know how to unravel that yet, but you've at least made me see the knot that I'm sort of tied in there. So, Brian, why don't you go ahead with the framing phase of your presentation?
Okay. So, framing and messaging are two things I wanted to cover, and they are distinct and different. But it's important because it's how we talk about issues, and it shapes our public policy, and it shapes people's perceptions, how they view or define various issues. So what's a frame? One of the most long time used frames is, a short phrase: tax relief, tax fairness, or as our former president used to say, our depleted military. And often these things are repeated over and over and over by various, print, electronic, or social media. So these things become second nature. Well, who would be against tax relief? Who would be against increasing defense spending because our military is depleted? But it also just cognitively helps us process our everyday life. Like, I'm going to go to the dentist. So dentist frame, we know what that's about. We know what to expect when we go to the dentist. And this is based on considerable cognitive and neurological research. The term frame was popularized by George Lakoff, who wrote a book called Don't Think of an Elephant. And if I tell you don't think of an elephant, what do you think of? An elephant. So these are just linguistic concepts or frames or shortcuts, if you will, to help us process information more quickly. So people tend to understand ideas within the context of these conceptual frames. And again, a frame is just a phrase, generally, a few words or that trigger whole frames and reinforce or don't reinforce your interpretation of certain issues. So, and framing is different than messaging. Messaging, again, uses words, ideas to trigger an emotional response. And this is a real key. And I've researched this issue when I was a candidate, that politics is extremely emotional, which is not a new concept. But for example, people don't remember what a candidate said. They remember how they felt about what the candidate said. That's why it's important for candidates to talk about their values, to connect with people emotionally. So an effective message creates a memorable and compelling takeaway, for example, behaviors or the phrase I use that, mental illness is not behavior. And often these messages, again, like a frame, reinforce or challenges our thinking about different issues. So here is a slide, for example, of the current initiative to remove the capital gains tax. So the yes people have very, very short frame: vote yes, pay less. And their messages, you can see there, we need to protect entrepreneurs. This would punish innovators and small business. And of course, they use the slippery slope argument that, this is just going to lead to a state income tax, which in their view, we can't have. So the no people, their frame is no cuts to education, no cuts to childcare, and you can see the associated messages. So what I'd like to do now is talk about 4 mental health frames. And I'm sure a number of you have heard some of these before, especially help, not handcuffs, healthcare, not a hurdle, prevention is power, and invest in minds, invest in futures. And some of this work comes from what's called an organization called the Frameworks Institute, which does a lot of social science and sociological research on framing and messaging on a variety of social issues. So, help, not handcuffs. What are we doing here with this? We're reframing the debate and viewing mental health issues not as criminal behaviors, but health conditions that require treatment, empathy, and support. So this frame suggests that people experiencing a mental health crisis deserve compassion, care, not criminalization. And it emphasizes that our responsibility as a community is to help rather than punish people in distress. So I'm just kind of explaining why the frame is effective and what you can do with it. So here's some examples of some messaging resulted for this. Mental health conditions are medical issues, not criminal ones. They need care, and they are not offenders who need punishment. Again, this phrase that I like so much, mental illness affects behavior, and behavior can affect mental illness, but mental illnesses are not behavioral. And this shifts the narrative from thinking about somebody who's a criminal to a patient, and therefore needs empathy and a moral duty to help that person. So that's actually one of my favorite frames. Next, healthcare, not a hurdle. And the framing concept here is mental health is health. We need to eliminate the stigma and obstacles that prevent people from seeking help. No one should have to jump through hoops to get the mental health care they need. And then here's some accompanying messaging with that. As Dr. Wu mentioned, we need to treat mental health like physical health, and that means accessible services, no stigma, and comprehensive coverage or mental health parity, as some federal and state legislation seeks to do. Mental health is part of whole health. You wouldn't deny somebody care for a broken arm. We shouldn't deny them care for their mental health condition. Prevention is power. This focuses on the effectiveness of early intervention and preventive mental health care. Empowers both individuals and overall community in reducing crises and long-term impacts. So some messaging associated with this is that, preventive mental health care is very powerful. It keeps people healthy and reduces the need for crisis intervention. Just like we prevent heart disease with regular checkups, we must prevent mental health crises with early and ongoing support. And prevention empowers us all. Early mental health care means fewer emergencies, less suffering, and stronger communities. I think this is one of the tenets of the Healthy Children's, initiative in terms of the more we can prevent or minimize adverse childhood experience, it's extremely cost effective to our society going forward. And then finally, invest in minds, invest in futures. This is somewhat similar to the preventative frame, but this is an investment in individuals' potential, the well-being of our community, as well as economic prosperity. It's not just compassionate policy, it's smart policy. And it creates a healthier, more productive future for everyone. And so here's some accompanying messaging with that. It helps people stay in school, stay employed, and stay engaged in their community. The cost of untreated mental health issues is far higher than the cost of providing care early and effectively, just like the cost of diversion from the jail for somebody with a mental health condition is much more cost effective than having them incarcerated. So that was 4 of the frames I wanted to talk about. Is there any discussion on framing and messaging before we go into this next series of slides?
Brian, a lot of the messaging is an attempt to reverse the way people look at mental health and mental illness. And those are long-standing, deep-seated, continually reinforced in real time kinds of viewpoints. The equation of mental illness with violent behavior, for instance, is one. And so, and you know, to message no stigma, I'm not sure what that turns into in a practical sense. Are there effective approaches? What is NAMI doing with that? How do we go beyond the talking, which is trying to overcome something that a lot of people aren't even aware is questionable, the assumptions that people make about mental illness. What steps are effective in trying and actually starting to turn that perspective around?
Well, you know, I have worked with a number of candidates, like when they're talking about, I'll give you an example with Representative Timmons, and he is promoting social and emotional learning. And that's the frame for that type of, you know, early intervention. But some on the other aisle are not, I don't think that's a good frame for that. And I talked to him about this. And I think a better frame for that would be, we need to support students with wellness and resilience. I like that much better. It's the same thing, but and then you can go into your messaging about why that's important. But think about how tax relief has been in our lexicon for decades. What if, let's flip that, and what if people talked about tax fairness for decades, over and over and over and over again? That's what the frame does. It shifts, it reframes, it shifts the thinking. So when you talk about healthcare, not hurdles, or help, not handcuffs, anytime you're talking about the intersection of mental health and our criminal justice system, you know, like I do lobby day with the National Alliance on Mental Illness every February on President's Day. And I try and tell people, when you're talking about a mental health issue, give them a little kind of a yardstick or a phrase, you know? Like, I believe that people who are mentally ill and encounter our criminal justice system, I believe they should get help, not handcuffs. And here's why. It's just a mental shortcut to help reframe how we talk about mental health issues, and particularly in the criminal justice system with help, not handcuffs. So does that answer your question? Is that helpful, or?
Partially, yeah.
Okay.
There's a lot more we could go back and forth on that. And
well, what else do you think we should be talking about?
Well, I'm not sure this is an ongoing internal conversation I have. It's one thing to talk to Joe Timmons and try to get him framing things right. It's another thing to talk to somebody who's already decided which presidential candidate they're going to vote for and which message.
Sure.
So I mean, there are some people who are deeply invested in perspectives that are not healthy for the community, are not accurate in terms of medical science.
Well,
how do we reframe how?
Well, I think when it comes to gun violence and mental illness, I think there's a lot that reframing can do. Research has shown that people who suffer from mental illness commit crimes at a much lower level than the general public. And just because you're a mass shooter does not necessarily mean technically that you're mentally ill. You can be angry, you can have some other issues, but that in and of itself is not mental illness. So whenever there's a mass shooting and they say, well, you know, we just need better mental health treatment, I mean, certainly that's true. And the other thing I'll just point out, that there's 66 people that commit death by suicide every day in this country. Is that breaking news compared to the number of people that are killed in mass shooting events. But I do think there's a lot. You're absolutely right. There's so many other frames on the other side. You know, there's gun violence. If everybody got mental health treatment, we would significantly reduce gun violence. It's a struggle. It's a real struggle to get some of these, but often it's shifting the narrative when you talk about mental health to a positive impact, and also shifting it to where you're talking about it as a community responsibility, not necessarily putting it on individuals. For example, adverse childhood experiences, you know, that's really a community responsibility. And when you think about it, you know, it takes a village. So many of our members of our community that are incarcerated usually had some number of adverse childhood experiences, you know. So I'm not sure, it's kind of a rambling answer to your question, but I'm just offering that as potential food for thought.
No, thank you. That did move my thinking forward some, and as I said, I look forward to batting this back and forth with you in the future. Dan.
Yeah, I just want to kind of ground us back into the work of the committee here. I think, Brian, you bring up some really good points in terms of like the framing and versus messaging, and you know, all these components that you're talking about. But I do want to reground us into the work that we are charged with doing by charter by the county council, and that is to make recommendations to the broader task force on issues related to mental health illness and substance use disorder. And then therefore that would go to the county council. And I just want to remind the committee members here today that we are charged with that's our mission. And we have a substantial body of work when it comes to how we work with the Justice Project operations and implementation project when it comes to the new jail facility and associated behavioral health services. In particular, I want to call out the Division Street property that could be turned into an extensive behavioral health campus. We already have the Andeacon Center for Hope. We have Dijwalik Clinic from Swinomish Tribe coming up with their 2 mobile medical units, and we have a potential to repurpose the building that's there into a broader medical and service provision facility. So I want us to really think about, you know, moving forward, we're getting educated today, but moving forward, we must consider what recommendations do we want to provide to the broader task force and then to the county council. So just please consider that in your thinking. I know it's a lot to really consume today, but please consider that, and thank you.
Thanks, Dan. Dr. Wu.
Yeah, this is a bit tangential, but along the lines of your previous question, Steve, how do you address this issue with people who seem really entrenched in thinking of mental illness as a behavioral or voluntary problem, or as, you know, somebody else's responsibility, or responsibility limited just to their own family? In my experience, and statistically, it is extremely likely that anyone we know has a close connection to someone with mental illness. And I often find that resistance to thinking about it as a true illness comes from fear or grief from the experiences they've had before, either themselves or with a family member. And so I think I don't think you can argue people out of that position. I often find that if they are listened to for long enough, they eventually will tell you what their vulnerability is that has them so entrenched. And oftentimes it's someone they were very close to who's suffered very badly from mental illness. And it's just a dysfunctional way of dealing with that grief.
That's very helpful and very insightful, Dr. Wu. Thank you very much. Pam, I notice you affirming that. Is there anything you want to add from your clinical perspective?
Well, I have to say, I just totally agree with Dr. Wu. And I also think that the difficulty is we define so many things as mental illness. So I think that's a tough situation because, you know, people that have a lot of adverse childhood events, sometimes a best treatment is a behavioral treatment that may include consequences for behavior that's dysfunctional because it helps learning. Other times, that's not the case at all. So I'm kind of struggling with some of the talking points. I kind of want to reword them, but I understand the importance of not making them too complicated. So I'm just internally myself struggling with that a little bit because, yeah, for example, I'm afraid that help not handcuffs would lead to, oh, sure, all you're doing, you know, you're just throwing more stuff at them. They're getting stuff for, you know, behaving that way. I mean, I just, yeah, I'm struggling with some of these. I don't know, Brian, if these are tried and true tested frames, or, yeah, where they come from. I mean, I see the Ford Foundation, maybe they know those as effective talking points.
Well, I'm going to breeze through the rest of these slides because they kind of a little bit of repeat. But again, I would encourage you to take a look at the Frameworks Foundation. These are PhD social scientists that do academic research and focus groups on how to communicate social issues to the public and how to reframe certain issues. And most of their documents are free. And if you do a search on mental health or mental illness, they've done a lot of research on how to effectively talk and reframe things. And one of their big, like I said before, like in terms of childcare, is to reframe childcare as a community responsibility, not an individual responsibility. And in some of these slides here going forward, you know, like you said, Pam, the general public does not understand mental health really at all because they attribute so many things to it incorrectly. So I don't disagree with what you're saying because sure, some people are going to say help, not handcuffs. These people are criminals. That, you know, you do the crime, you do the time. But again, it's a, you know, when you have informational deficits, it takes a long time, decades, to overcome those or reorient people's thinking. And groups like the Frameworks Institute, this is what they're trying to do, is reframe the debate about a variety of social issues. So, and it is based on science. It is based on like focus groups. And so they're not just, you know, making this up. It's backed by research, and they usually have and for any of you that use AI, some of my presentation was based on Chat GPT research about, for example, I would ask it, using political framing, could you write me a 2-page article that explains and uses political framing and messaging to describe the difference between, you know, behavior and mental health disorders with references? And you'd be surprised at how concise and coherent and convincing that output will be. So is that helpful? I think you're muted, Pam.
I think so. I mean, I find the whole AI thing kind of terrifying, to tell you the truth. Helpful yet terrifying. And yeah, I appreciate the reference to the science, and I clearly need some more education on that point. I believe that I'm sure social scientists are involved in doing that. I also was just finding myself wondering, you know, how long ago it was that we blamed people for physical disabilities. We used to think, you know, there was something wrong with people, that, oh, they're crippled, right? You don't want to get too close to them because they're cursed in some way. And I wonder how long that took for us to, I don't think many people of, you know, a large political spectrum would continue to think that way. And I want to know, like, how did that shift? That's what I'm curious about.
Well, I think sometimes it can take a generation or a decadal change. I mean, look at the young people's attitudes and how comfortable they are talking about mental health compared to people that might be my age, for example. I mean, so in some cases it's a generational change. Like, I mean, gay marriage, for example. Look at the evolution of something like that.
Hey, Brian, we're gonna have to move this thing along. We're
Yeah.
at 9:47 right now.
Yeah, you know what? I'm gonna stop right there, and people that are interested can look at the rest of these slides, because I did want to talk at the end of this meeting very quickly about, are we going to have suggestions to the overall task force and to the executive or council about their legislative agenda for the upcoming state legislature related to mental health?
That's a great question. Let's get to that at the end of the meeting. I think that we do need to cover that ground. Dr. Wu, your hand up still. Did you have a question? Okay. All right. Okay. Okay. Thanks, Jill, for putting us back on the screen here. I noticed that Heather Flaherty has joined us. Welcome, Heather. Thanks for being here. We've got some other folks in the gallery, including Dean White and Iris Knott. Iris is our policy analyst for the Bellingham City Council, and Dean White works for the Whatcom County Health Department as a consultant. So welcome to those folks here today. We have some other agenda items, and I want to make sure we provide ample time for them. And hey, Brian, thank you for that presentation. That was really insightful. It's good to really, to really think about and consider those issues, and to kind of retool our thinking as to how we deal with mental health illness and substance use disorders. So thank you very much for that presentation, those items. I believe our next item, we've got a couple items from Dr. Wu here today, and I wanted to invite him to discuss the trip to Los Angeles to meet with Homeboy Industries, and then also to talk about a generative item that Dr. Wu's come up with, and I want to discuss that. So I just want to provide enough time for that. We're at 9:49 right now. We go until 10:30, so we got a little bit of time. Doctor, you want to go ahead and discuss?
Sure. I think I'd like to do them in the other order if I could.
That's fine. That's totally fine.
So let's see. So a couple of weeks ago, September 18th, there was a bunch of stuff in the news. I saw an article from NPR about drug overdoses dropping precipitously. And, everyone was talking about how that's great news. And I think we have seen some of that reflected locally. And, the overdose rate seems to be down. And the thing I took away from those articles is nobody knows why, right? So these are national experts, state health officials, and they're saying, well, we think maybe it's because we have more naloxone out there. Maybe we have more treatment. Maybe we have better support services. But as one of them said, it's a mystery. And it's quite steep if you look at those graphs. And I'll forward maybe Jill after this a bunch of references and websites and things that you can look at. But it's quite a steep drop, and I think our local law enforcement and emergency room and medic services have felt the same thing. My concern, as I voiced before, is that I'm not sure. I love that we do have more naloxone out there, and we are doing better support services, but I am concerned that we're on a bubble because of perhaps a safer drug supply, and that if we don't have more information, we could be headed for a very disappointing event in the future. My suspicion or my concern is that perhaps the drug supply is of lower potency in general, or perhaps it is more consistently dosed, so that if you get 6 foils, none of them have a potential overdose in them, whereas the 7th might. Maybe a month ago it was 1 in 5 instead of 1 in 7. I think we're flying blind as far as this particular issue is concerned. The chemistry of this is not that difficult a problem. I think the information could be obtained if we had a sample of drugs available from the street, from local dealers, and I've been told that our local law enforcement would be able to provide us with that. And then a laboratory that would be willing to not just test them in aggregate, but to test them, one dose at a time, and tell us both what the potency is and what the variability is in those doses. Now, the question I think then is, what would we do with that information? But, I liken this to, every once in a while you get a food recall because, ice cream from so-and-so is contaminated with listeria. It's considered a public health issue. And wouldn't you want to know, that potentially there's a dangerous dose out there for you? I think this is no different. It's a public health situation. I think we tend to think of it differently because this is a much deeper problem, but I think we think of it differently because we think of people as addicted to drugs as somehow being less valuable human beings than the rest of us. And so we don't think of it as a public health issue, but it really is. So that's my question is, if we could access this information, so, get a representative sample of street obtainable medicine, test them dose by dose for potency, what would we do with that information? What would be the potential good outcomes or efficacy that we could get from that? And what would be the potential unintended consequences? The first one that came up is, well, if you have a really hot batch in town, would people actually seek that out to have a bigger effect? That's a possibility. I suspect that already happens based on, street knowledge. Would we be reinforcing that behavior? I think that would be one potential negative concern. On the positive side, best case scenario, someone looks at that information and says, you know what, I've had 2 overdoses before. Maybe I don't want to overdose. Maybe I'm going to seek treatment. That would be a great outcome. But perhaps a little less. I mean, I think that could definitely happen sometimes, but perhaps a little less pie in the sky. Maybe people might say, I think I'm just going to make sure I've got my naloxone with me, or better yet, maybe I'll make sure I've got naloxone and another person with me so that I'm not using alone. Or, there is a phone service called Never Use Alone. Their website is, www.neverusealone.com, where if you are going to use alone, you can call them and they will stay on the phone with you and keep you talking to them. And if you stop talking to them, the first thing they do is they obtain your exact location. And then if you stop talking to them, they call EMS for you. So that would be a third option that might have some efficacy. So I just wanted to put this idea out to this committee and see what people thought about, is this worth pursuing? What are particularly other unintended negative consequences that you can think of? And Dan, I think you had some additional information from Border Patrol that you might want to share at this point.
Sure. Thank you, Dr. Wu, for that framing. We've got a number of providers here on the call that may have opinions, and I see that Captain Larson, you've got your hand up. Go ahead, sir.
Yeah, I like the concept of, information is powerful, and having that knowledge of the potency to it is good. And I think if it was kept at like the provider level or the responder level, like, oh yeah, we're knowledgeable of this current batch of fentanyl in the system, or what the batch that we tested is high, I think that just maybe can heighten people's awareness and how we prepare better. I don't really know. I don't think much will change there, but just having that knowledge would be great. I think providing that knowledge to the community, the users, would maybe be not as beneficial. Like you've already highlighted, like I think, would people then seek it out because of that? And then if like, if it's not potent, are we downplaying the non-potent fentanyl, which is still, as we know, can harm people and kill people? So I think it's like, it's a good batch right now, or it's not. Either way, it's still a lethal medicine that. So I think if we were to test it, which I don't have a real strong opinion one way or the other. I think it needs to stay at the provider level and not the community level. My 2 cents.
Thank you. Thanks, Steve. Appreciate that. Good information. I want to provide a space for the other folks that are medical professionals and providers here on the call to chime in if you'd like to. And you don't have to raise your hand, just go ahead and speak if you'd like. Okay. All right. Seeing none, I'll go ahead and kind of move this conversation along a little bit. So what Dr. Wu is referring to is called bad batch phenomenon. And it just basically means we get we have the constant flow of cartel fentanyl that comes into the community, and occasionally there's a bad batch of potency that's lethal, or parts of the batch could be considered lethal. And the question is, do we then well, there's a number of questions. One is, can we test in real time? And the answer to that is yes, through different authorities that were just briefly mentioned here on the call. And if we can do that, or when we can do that, could we then notify providers, as Captain Larson mentioned, and then within those provider networks, a HOT team, the homeless outreach team, MCOT, ART, other service providers, could we then notify people that could be using, and would there be a benefit to that? And I think that we've covered that territory a little bit. I think that there's probably, some benefit to folks who, as Dr. Wu indicated, may have overdosed before, or just are ready to seek, treatment or services, and that part of the community could benefit from it. And then the others, and this is feedback that I've gotten from first responders, is that some people would seek that batch out. So we have to balance this out. This is one of these generative ideas that has come from one of our members here from the committee, which we highly encourage in terms of thinking through innovative responses and ideas when it comes to the work that we do. We're not solely here to provide recommendations, policy recommendations. We're here to construct ideas. And I want to remind this group that the alternate response team, the GRACE program, and to some extent the LEAD program, in some form or fashion, came out of this group. So we have a track record of putting forward very innovative and helpful ideas, and this is a new one. And I want us to think this through and to make sure that we see all angles, and we make sure that the committee has chimed in and provided feedback to the person of origin for this idea, and that's Dr. Wu in this case. And so and we've had a few conversations about this over the course of the last few months. So I want to provide the opportunity for the committee to chime in if you wish. It's your time here this morning. We've got a little bit of time to discuss this. So here's your opportunity, folks. Pam, I see you moved, and Mike Hilly, go ahead.
Yeah, thanks, Dan. I listening to Steve talk, and I agree. I'm not sure the value of testing and then pushing out batches that are currently in or out are good or not hot or not, because there's just so many variables in how this stuff comes into the county and the region. But what I do notice and watch almost every day is the number of overdoses that are going down in the community in the last 24 hours. And when I see cluster overdoses, and these clusters are occurring within, the same couple of 3 square blocks out there, I think that's a big indicator to say, hey, something's wrong out there. Something's going bad. You should be watching what you're doing out there, because we'll see these clusters of 5 or 6 or 7 in a given day and in a geographical area. And that's not just downtown, by the way. I've seen that out in Kendall. I see clusters up in Sumas, other areas of the county where you wouldn't think this was actually, going on in a big way. So I do think it's valuable to somehow to respond to that. And actually, to your comment about an opioid response team, I absolutely agree. We need to get an opioid response team on the ground. I know the health department's working on the concept as part of the executive order. So how do we do that? The first piece is, from my perspective, is having somebody that can respond real time to that call. I think EMS should be part of that response because they can do it quickly, swiftly, and support the teams that are waking somebody up. But for those overdoses that are missed, yeah, the follow-up is extremely important. So even in those clusters, if we saw that, we could have the opioid response teams respond to those cluster areas and talk to those patients and see what happened and what's going on, and create a bit of an intel or network of how we can, respond better to that as a community, not necessarily from EMS, from law enforcement, to educate people about that. So, but I do think it's important to get that out there somehow. I mean, I do that every day with sudden cardiac arrest. We talk about all the things that you can do to prevent sudden cardiac arrest are out there, and bystander CPR and AEDs and all that. I kind of see this as a similar situation in reporting and understanding and responding. So yeah, I think something needs to work in that direction.
Thanks, Mike. Hey, Pam, I saw you. I don't know if you unmuted. Go ahead.
Yeah, I was just wondering, and this may have to do with my inexperience with just all the community organizations, but is there been discussion about this with the opioid task force? And that they meet, I think, monthly or every other month regarding efforts to prevent and deal with the opioid crisis. I just wonder about that.
Heather Flaherty, do you want to respond to that?
I do. I think you bring up a really good point. This is a little aside, but for each of the IPRTF committees, there are an associated 1, 2, or sometimes even 3 other work groups working in the county on the same issue. And I think there's maybe a steering committee conversation about how do we make sure there are appropriate linkages all around so that this body can have informed conversations. Because I don't think that the opioid task force, I don't think there's a clear linkage between this conversation and the conversations happening at that task force. I don't think that task force is like an open public meeting. So I don't think any of us can just go drop in. I don't even know, maybe Mike Hilly, are you on that task force? Maybe you would know more about that, but I think there needs to be more coordination and linkages between the internal program work and the community members there and this body.
We send someone to that. I don't go to that meeting because I've got a lot of people that are interested in going. So I say go. But that as providers, we have that link. And I just, I guess I kind of agree with you, Heather.
And then just to Heather, I do attend those meetings. In fact, I think there's one coming up next week. Most of the topics out of that group have been more oriented to prevention services, and most recently the opioid fund distribution. And I know Joe Fuller is actually leading the opioid settlement funds for both the county as they distribute that for the city. So that's been the bulk of the conversation. But I agree, that task force has been around for a super long time, and actually even really before the fentanyl crisis just had reached that peak. And so there's a lot of other groups addressing the response part, but the opioid task force really isn't oriented, from my perspective, about the response, about the community response. It's more about prevention, education, and once again, the funds that are coming in now.
Thanks, Mike. Thanks, Heather and Pam. Yeah, I think that, Heather, you're right. I mean, we all exist in our silos, and we do have representation from the city. Skip Williams is on that committee, but we don't have cross conversations as much as we need to. And this idea that we're currently discussing, I don't think it's been brought up in any meaningful way with that committee. But it would be helpful to have this idea vetted further beyond this committee. I mean, we're 15 people right now on this call, and it'd be helpful to have other providers weigh in to see. And we don't have PD representation here today. I think we lost one of our members to a job transfer. We do have Captain Larson, thank goodness, from the Bellingham Fire Department and he's obviously chimed in. So I think that further, I think this idea needs further vetting. That's where I'm at right now. Stephen Gockley, do you, as co-chair, do you have any further discussion on this?
No, I agree, Dan, that there's merit there. There's reason to look further into it. Dr. Wu has thought pretty carefully about it and brought up some good perspectives, but so have Mike and Captain Larson. And I also agree with Heather's point about the coordination, so that we're not stumbling over each other. I'm not sure how to proceed with further vetting. My sense is that there is a cluster of people who participated in this conversation who might have between meeting conversations to try to shape some specificity to the next steps forward on this idea.
Okay.
My thought.
Okay. So I'm going to recognize Dr. Wu and Captain Larson. Then I've got a comment. Then we probably need to move on. Go ahead, Dr. Wu.
Yeah, so I just want to say a couple things. One, I don't have any personal emotional investment in this idea. You know, it may have value, it may not. So no one needs to worry about hurting my feelings about this. Maybe, you know, if it's not worth doing, we definitely shouldn't waste time on it. The other two thoughts I had is, you know, I was struck by how the national article said, well, we don't know why this is happening. And so at a policy level, I think it might be useful to have baseline information about what's the potency of drugs and what's the supply of drugs coming into the country. It sounds like, from what I could see, nobody else is doing this. And I just think that it would be nice to have a baseline. It would be nice to be able to know what's coming in, and to know what the risks are just on an ongoing basis. Yeah, so I think that's one additional value. In terms of other people to talk to, I would be really curious to see what the folks who are going out in the field and talking with folks like Homeless Outreach Team would think about this, and do they think there's any value to it? Maybe they, you know, maybe they'll be like, nah, which would be fine.
Thanks, Doctor. Go ahead, Captain.
Thanks, Doc. I think you kind of answered it. Do we know if there's any agencies locally, statewide, that are doing this? And I mean, I think that's the easy thing to compare and what value they've gained from it. But yeah, if there isn't, then, but if there is, I think we should probably see if it's a valued process.
Does anyone have a response to Captain Larson? Hannah Fisk, do you know from the health department perspective, is there any data that could be answer that question?
You know, I don't know off the top of my head, but I definitely will go and ask. I know that there are other places that test if the participants are willing, right? It's a voluntary thing to bring in your substances and have them tested, and there's some really great machines. So it'd be interesting if it's done on a broader scale. And I think that this is great, if, especially couched under prevention. So I think we do talk a lot about the opioid response and having someone go out when there's an overdose. But if I'm hearing this correctly, this is actually to prevent those clusters that Mike was talking about, right? So this potentially could save or stop a cluster from happening if that education got out saying, hey, there's a high potency out there, please be aware. That could save some lives. So I really look forward to hearing more about this, and I will definitely bring it back to our teams to see what's out there and what their thoughts are.
Thanks, Hannah, for providing that. I'll just briefly make a comment. I think that this idea still has merit and value, and I think that we should still consider this as something that we could do as a fairly reasonable action item. I do want to make sure that we have law enforcement chiming in on this from Bellingham. I mean, that's the jurisdiction that I work in, so that I will continue to reach out to our folks there. And just in the interest of time, so it's 10:11 right now. We've got 19 minutes left here in the meeting, and I wanted to make sure that there's time for Dr. Wu to discuss a second item, and then I have a brief update, but from the city side, but and we may or may not get to it. Go ahead, Dr. Wu.
Okay, so some of you have heard me talk about Homeboy Industries before. I will just give quick background. So they've been around for about 30 plus years. started by a Jesuit priest who noticed he was doing more funerals than baptisms for young people in Los Angeles, who were, he worked in a parish which was heavily gang involved. And sort of by improvisational hard work, he hit upon a model of helping people who were incarcerated or gang involved to re-enter society as productive citizens. And now he is sort of on loan from the Jesuits to this program that has run in Los Angeles ever since, called Homeboy Industries. I'll include some links in the email that I sent to Jill. But long story short, they are the longest running, most successful, largest incarceration re-entry program in the world, as far as we know. And they typically they serve about depending on how you count it, 7,000 to 8,000 people in the community a year. They have about 400 people at a time in their 18-month job training program. And their recidivism rates are typically less than half of the standard for their area. So their recidivism rates on average run about 30% compared to about 70% for their jurisdiction in other programs. So, in terms of this would count as not prevention, but intervention for people who were already justice involved if we were to replicate something like this here. They are very community focused, so they're not interested in scaling by, as one might call it, franchising out their model to other places, because they think that it really needs to be community based. But a few years ago, they started a thing called Global Homeboy Network to support other communities or organizations in doing similarly minded work around the world. And now there are hundreds of organizations and communities around the world who are using these basic principles. So I will just say that in these conversations, we often don't talk, we're largely talking policy and issues, but I think we often skirt around what are really the essential things for healing and recovery, which, are often thought of as emotional or humanistic issues, but I think are actually really the real substance of policy in this area. Because if we're talking healing, then we need to talk about community, connection, committed, unconditional, positive regard, love, and belonging, right? Because in my experience, when people recover from really difficult situations, it almost always involves a tight personal connection to one or more other people. In my experience, for people in recovery, it's usually their kids that, or concern about their kids, that is the strongest motivator for them to be in recovery. And so I think, we need to talk about these issues because, and we need to elevate basically love, family, community, connection, belonging to the policy level, because if we don't, we're kind of missing the boat. We're not talking about our most powerful interventions, if you want to call them that. And I think so Father Gregory Boyle, who's the Jesuit priest who started this, I think what he does such an amazing job of is consistently elevating those points into policy level discussion. So I've been reading his stuff and listening to him for years. My daughter recently took a job in Los Angeles, so we went down to visit her. And since I was there, I thought, well, I should go and see if they really are what they say they are. I kind of figured they would be, but you kind of got to see it for yourself sometimes. So we parked the car next to Chinatown. We started walking over towards Homeboy. My wife came with me, and we're a block and a half away. And the first thing I noticed is that 30% of the people on the street were wearing Homeboy merchandise, which I'm now proudly wearing one of. And then as we got closer to the building where their cafe and training center is located, I noticed that there were a lot of people who were just hanging out, having conversations on the street, most of whom were wearing Homeboy merch. And they were having really positive, animated, engaged conversations. And then as we got to the building entrance, there were like 4 guys who were standing in the door that we thought we needed to go in. They were kind of blocking the way. So I asked them, if this was the right place for us to go. And it turns out they all work there. And they were just incredibly friendly, really supportive. They were like so glad that we were there to take a tour, and they directed us around the building to the proper entrance, where there were like 15 people sitting outside having lunch together, having what was obviously a community conversation. And it was just like that for the whole time we were there. And we met. I was just impressed, not so much by how friendly they were to us, but how friendly everyone in the institution was to each other and how supportive they were. The woman who took us on our tour had 9 months sober. She'd gotten her kids back. She was in their job training program. She was planning to go to college and become a substance use counselor since she was recovered from meth addiction herself. And this is basically what we heard from everybody. We ate in the cafe. We looked at the bakery. We talked to their job reentry person. We talked to, I don't know, half a dozen other people. And basically, if you read the books or you listen to the podcast, I think they really are what they claim to be. And I would say they're cost effective. Their numbers bear them out. Their cost per participant is less than the cost of incarceration. It's a little hard to calculate because they do all kinds of services. But even if you just limit it to the people who are most intensely in their services, it's no more expensive than incarceration. Their long-term success rates are very high. I think, if this is our charge from the county, I think it would behoove us to look at the most successful long-term program in our country and see if maybe joining Global Homeboy Network would be a reasonable thing for our county to do as an effective intervention for reducing incarceration and preventing recidivism and promoting healing and community. So that's my pitch.
Thanks, Dr. Hu. Well, you've taken up two generative items, including this one. So you get the prize for most active committee member. I think I think you're right. I mean, and I'll let others weigh in here, but I just want to briefly speak. I think that community is part of healing, and lack of connection just perpetuates the issue. So the more that we can connect people together, the better off we're going to be, and that includes both substance use disorder and mental health illness. Committee members, do you have any comments on what Dr. Wu just mentioned? Dr. Separate, go ahead.
Yes, well, I have had heard about this program before, but recently read some of the books at Dr. Wu's suggestion and loan, and I would second everything he says. And it actually reflects the work that our local tribes recently did on looking at the causes of opioid use disorder and solutions. And their biggest takeaway, at least that I took from hearing the presentations, was the importance of community and belonging. And if a fish is swimming over on the margin and not making it too well, it's everybody's responsibility to find the fish and help. And that's kind of a different way of saying the same thing that is being demonstrated over and over again in Homeboys. And it kind of resonates with what Brian said earlier. It's about how do we make our communities healthy? And we can't make our communities healthy in the place that we're often driven in our current society of more isolated existence and more fragmentation. So I would wholeheartedly support both a site visit for those who want to see the actual on the ground way it works, and also support joining and really saying this is one of the state of arts in our nation, and therefore that's what we're tasked to do: look for best practices and bring them here.
Thank you, Doctor. Heather Flaherty.
I love this concept and this learning, and I think that this could be, Dan, when you talk about, like, we also develop programs, this could be the next focus with the on that program level. with the return you get on the reentry services. I mean, there's a lot of concepts I think you could combine, and I just want to raise my hand and say I'd love to help with that. What partners need to be there? We now have the way station that's opening. The 23-hour behavioral urgent care is going to come online. And so how can we continue to build out the coordination and potentially have that reentry homeboy support as well? So
Thanks, Heather. Recognize Brian.
Yeah, I just had a question for Dr. Wu. I went to the Global Homeboy Network webpage, and it lists Washington State as participating in the Global Homeboy Network. Are there any organizations that have developed this program in Washington State that you're aware of?
Yeah, so I was the only one that I found is a church in Mount Vernon, or in Skagit County, that is working with. I think their program is to pair a released inmate with one at a time with a church to help them provide that community. And I have not contacted them.
I've checked that, doctor, just for some info on that. So the Accountable Communities of Health actually been providing a good bit of funding for that project out in Skagit County. And yeah, it's a program that, while it's church-based, it's not religiously motivated, to take people that have been previously incarcerated, get their license back, help them find jobs, housing, etc., or give them skills. And so as we develop this conversation, I think the Accountable Communities of Health might be able to help with that, just because I know they're funding similar projects around the region to that effect. So Liz Baxter is the CEO, and it might be worth a reach out to her to maybe even give a presentation on those types of things she's funded, or the ACH is funded.
Thanks, Mike. Mike, it might be helpful. It sounds like we're kind of forming a path forward here, and I don't want to drop the ball on this. I think that, Heather, I think you're correct. I think that we could move this forward. And folks, we've got a tremendous amount of responsibility when it comes to reentry advice and recommendations for the new jail facility. And we can get it right or we can get it wrong. So let's try to make sure that we put our best foot forward. Mike, I'm wondering if you could help bridge us in that regard, and maybe connect Dr. Wu with those resources, and maybe we form some kind of subcommittee. If we have an asset that's literally down the road in Skagit, let's start asking questions. So that's a good place to start. Is that something you can do, Mike?
I'd be absolutely glad to do that. We have a great relationship with the ACH out of the EMS office, so absolutely.
Okay. And Dan, if I could, I just wanted to reiterate what Jill Nix had said one time, is that most of the initiatives of this committee, like creation of the Grace Network or the SIM or other things, came out of a work group. And so I would be willing to be on a work group like that if in fact that makes sense to put that together. But for the newer members, that's often how specific concepts are moved forward and are implemented in the community.
Yeah, no, good call, Brian. So I would recommend that Brian, Dr. Wu, and Mike maybe put their heads together and try to figure out the Skagit, and maybe we do a field trip down there, in a month or whatever the case may be. But I think if we have a local, not chapter, but asset here that's related to that program or is part of that program, let's talk to them and let's ask questions and see how we can replicate that up here. Go ahead.
I'll volunteer to do a Google Doodle poll when we three of us can get together.
Okay, thanks. Appreciate it. Doctors Safford and then Hannah Fisk, and then
he has a hand up too.
Yep.
Just to notice, I just wanted to mention that Ying is a wealth of resources on this, and he does have several of the books. And I realize we're all enormously busy and don't have lots of reading time, but they're very entertaining and easily read. So if anybody is interested in reading one of the books by Father Boyle, they might find it kind of helps them get into the spirit and the day-to-day of it more easily than just reading about programs. So I'm sure in your emailing, you might want to include just a list of what you think the best ones are and where you can get them.
Thanks, Doctor. And there's also YouTube videos that are easily consumed. So, yeah, Hannah Fisk, go ahead.
Yeah, I just wanted to add that, which I'm sure many of are aware at this point, but I oversee the behavioral health contract for the jail that also includes the reentry staff. And so if there's evidence-based practices that support changing now, not just when we build a new jail, I would love to bring that information to that team. I think they're really innovative, they're really creative, they are always up for trying new things. So I think if there's something that we can start doing now that will change people's lives, that team would want to know. So yes, in the future, down the road, but I think that they would also welcome recommendations that maybe we can start implementing sooner. So just to keep that in mind as we move through this process.
Yeah, point well taken. I mean, yeah, we have interim work to do here. It's not just the new jail that's going to be on La Bounty in 5 years or whatever. We have work today, and so thank you, Hannah, for bringing that forward. Deborah.
Yeah, so Chris Hoke is the name of the pastor that I believe what Dr. Wu was talking about down in Skagit County. He calls it one prisoner, one parish. And he has been very successful in this. He presented at a presentation I went to about a year ago from was at Skagit Valley Community College. And he's also written a book. I had him pulled up here on my phone. The book is called Wanted. Anyway, also Skagit County is very progressive on their criminal legal system reform, and they're doing some tremendous work. This was an all-day presentation that I attended, and it included formerly incarcerated individuals that had stepped into the program in human services there that enabled them to become spokespeople, if you will, for criminal legal system reform. Anyway, I did mention to Jill the name of the judge that runs this program down there. I think it's called Community Court, and they have a completely different paradigm of where they're coming from with addressing reentry issues and looking at them in a holistic manner, like most of organizations and jails and prisons that don't have much reentry support look at it or recognize. So anyway, I would encourage us to be able to get Judge, I can't remember, Jill, what her name is. But anyway, she's the one that runs the community court down there in Skagit County, and it's extremely successful.
Thanks, Deborah.
Thank you.
We're basically at time right now. It's 10:29, and I just noticed that we don't have any public attendees, so we don't. I don't know, Jill. Are we still required to have public comment, or
we don't. I don't see anyone in our conference room either.
Okay. All right. So I want to make sure that we honor your time. I think it was a really great discussion, or multiple discussions today, and thanks to everyone for showing up and being a part of this. I'm really looking forward to the output of this work group that like spontaneously developed in the last 5 minutes or 10 minutes. So thank you for those volunteers that are willing to put that forward. Thanks, Hannah, for the offering of information, and thanks everyone for being a part of this very important work group and subcommittee of the task force. And with that, this meeting is adjourned. Thank you.